Hello everyone. This episode 20 of Spotters and Boosters pertains to case-based long question. Case is a middle-aged vegetarian pregnant woman from a rural city comes for examination at the secondary healthcare center, and she has been found to complain of increasing weakness and inability to cope up with the daily household work due to tiredness. She sometimes ate chalk. There was history of vaginal bleeding before pregnancy, which was diagnosed as dysfunctional uterine bleeding. She took incomplete treatment because she could not visit hospital regularly. No history was fever was there in the past. She was thin-built, pale conjunctiva and flat nails were seen, tongue was flat and bald, and no hepatosplenomegaly was there. The vitals were normal. Blood tests show hemoglobin 6.4 gram%, and the corresponding changes: packed cell volume 28, mean corpuscle volume 56, MCSC and MCH were also little reduced. RBC count was normal and white cell count was normal. Platelet counts were. Patient's ferrokinetics were done there, and compared to the normal ranges, patient had low serum iron, low serum ferritin, and higher total iron binding capacity. Transferrin saturation was also low. These findings suggest that patient was suffering from severe iron deficiency anemia. Now the questions pertaining to the case are: what is the therapeutic goal? This patient could not tolerate ferrous sulfate orally and developed nausea, vomiting, constipation. What is the alternative route of iron administration? Next question is: what are indications of parenteral iron therapy? Question 4. Enlist parenteral iron preparations that could be used in this case. Describe salient pharmacological characteristics of each of them and select a suitable formulation for administration. Question 5 is: how will you calculate dose and describe method of intravenous iron administration in such cases? And the question is: what are the adverse reactions of IV iron therapy and how will you? The question 1 is: therapeutic goal is to not only to treat the anemia by iron therapy but also to provide stores at least half to 1 gram of iron, and this requires sustained treatment for a period of over 6 months after correction of anemia when oral therapy is given. Now, correction of underlying cause is also important, otherwise persistent blood loss would be there. Usual treatment we do is cheapest is the ferrous sulfate 200 milligrams to be given 3 times daily. A patient can tolerate without meals is good, otherwise even with meals can be given. Then there is a co-therapy of folic acid because requirement will be increased. And there are a number of advices which must be given. Reticulocyte count and hemoglobin levels to be estimated regularly. Treatment is given initially for 2 months, but patient has to be instructed that further treatment will be required, so she should not stop treatment thereafter. Diet rich in iron such as meat, fish, liver, spinach, banana, wheat, germ, dry fruits should be taken, whatever she can take, and she should report if she develops intolerance to iron. She must also be told that harmless taste disturbance and blackening of the tongue may occur sometimes, which is not very. Is oral therapy sufficient? Usually, those patients who can tolerate iron on empty stomach or after meals can be continued with oral therapy in less urgent situations. However, in this case, there is a great need to correct IDA due to pregnancy. Rural location precludes frequent visits and follow-ups, and because of intolerance to iron, there is an indication for parenteral. So, Which patient will need parenteral iron therapy? Actually, or how can we know that iron is not adequately absorbed when given orally? This can be done in iron tolerance test. That is a simple OPD-based test to determine patient's ability to absorb iron. The method is 2 iron tablets are given to the patient on empty stomach, and the serum iron is measured serially over a subsequent 2 to 3 hours. Interpretation is the normal absorption will result in an increase in serum iron level of at least 100 microgram percent. If iron deficiency persists despite adequate treatment, it may be necessary to put patient on the parenteral. Indications are two broad indications of failure of iron therapy and acute and ongoing need of iron. Failure of iron therapy occurs because of intolerance, non-compliance, refractoriness, poor bioavailability due to disease of stomach and intestine, malabsorption syndrome, post-gastrectomy, bowel resection, proximal small bowel, irritable bowel, inflammatory bowel disease, ulcerative colitis, or Crohn's disease. Acute and ongoing need of anemia is seen along with erythropoietin therapy in anemia of chronic renal disease, severe anemia when rapid response is required as in pregnancy, and this can be made with IV iron, particularly when patient cannot be followed regularly. Now, parenteral iron treatment may be necessary for patients with excessive chronic blood loss that exceeds the capacity of oral iron absorption, for example, total parenteral nutrition, and patients on continued hemodialysis. There are various formulations available: iron dextran, age-old formula, iron ferrous sucrose, iron isomaltoside 1000, sodium ferric gluconate complex, ferric carboxymaltose, and ferromoxytol. These formulations are currently available all over the world. As iron dextran is older one, a stable complex of ferric oxyhydroxide and dextran polymers. Dextran polymer can be high molecular weight or low molecular weight. Currently, low molecular weights are available. Iron sucrose is a complex of polynuclear iron hydroxide in sucrose and alkaline, so it is not given intramuscularly. Iron isomaltoside 1000 is chemically modified isomaltoside, that is oligosaccharide, where iron is there in the central core. Sodium ferric gluconate complex is a complex which provides 12.5 milligram per ml of the iron. Ferric carboxymaltose contains 50 milligram per ml, and ferromoxytol 30 milligram per ml is the elemental iron in it. Lowest elemental iron is provided by sodium ferric glucose and then iron sucrose. Generally, these compounds are taken up by iris cells, macrophages, and then they release the iron slowly in the circulation. About 80% of sodium ferric gluconate complex transfers the iron in the blood without processing into RE cells. Similarly, ferric carboxymaltose is rapidly cleared from circulation and widely distributed into RE cells, the bone marrow, liver, and spleen. Now, characteristically, these drugs are given either as single dose or multiple doses. Particularly, our iron dextran is always given after a sensitivity test because of potential for allergic reactions and anaphylaxis, and iron sucrose is given in split doses of 200 milligram at one sitting, and the total dose is 1 gram to be given within 2 weeks. And this compound, when used continuously, may cause renal tubulointerstitial damage, and it is found to be inconvenient in pregnancy. This is because multiple dosing are needed. Iron isomaltoside can be given as a single dose, and it has very low immunogenic potential. So allergic testing may not be required. Sodium ferric gluconate complex is also found to be less antigenic and less uh, inducing anaphylaxis than commonly used iron dextran. It is considered to be avoided in pregnancy due to benzyl alcohol preservative, which is found to be fetotoxic. Ferric carboxymaltose is one drug which can be given either as a single dose or in two split doses, and it also has low allergic potential. And ferromoxitol can be given as a single dose, and there is a extremely low incidence of. Now, if you look at the cost, the iron dextran is the cheapest drug available for intravenous use. Then comes iron sucrose, and currently ferric carboxymaltose is very costly, and iron isomaltoside is also costlier. Therefore, cost consideration is also important. Two newer agents, merits and demerits of parenteral iron. We have to find out which one is good or not. Then parenteral iron can be given to iron deficient patients to create iron stores within 1-2 sessions. Otherwise, it will take almost months to achieve the same effect by oral route. It is dependable and ensures bioavailability and compliance, particularly as in pregnancy. GIT intolerance is avoided and stores are rapidly regulated, but that doesn't mean that it provides faster response for anemia correction. The correction of anemia is same whether to give orally or parenterally, and it is feasible because parenteral sitting iron can be given in 1-5 sittings. However, there are many demerits, particularly requires intervention, hospital attendance, visits, nursing care, and allergic reactions and anaphylaxis may occur. Muscle cramps, large number of ADRs I will be discussing can also occur with this, and cost is higher than oral therapy and it requires close. Now dose calculation by using various formulae. Most common, simplest to understand is use formula A, that is body weight multiplied by 2.3 and the difference in the patient's hemoglobin and 15 gram hemoglobin, plus add half to 1 gram for stores. Formula B, C can be used directly without additional amounts for stores. Formula D is very simple, that is 25 milligram elemental iron increases hemoglobin by 1%. If deficiency is 40%, it is simply 40 into 25, that is the need. Formula A is Ganzoni formula, which is devised for isomaltosides, but in essence the formula is same. Need of iron is body weight into target hemoglobin, say 14 or 50 gram, minus actual hemoglobin multiplied by 2.4 plus need of deposits. Methods of administration are two ways. One is total dose infusion to correct deficiency plus 500 milligram additional for replacements of the store, and this can be given either as single dose or split into 2 to 5 doses. For some IV formulations, 2 doses are sufficient, but it can be split into 5 doses as in iron sucrose. Second is intermittent smaller doses periodically are given for a longer time. Say weekly IV 100 milligram of elemental iron for 10 weeks in patients undergoing hemodialysis. So in hemodialysis unit, this method is used, and also when patient is. Now, method iron sucrose is perhaps the most commonly used agent today. It is a complex of polynuclear iron 3 hydroxide in sucrose and is given IV. When given IV, it is taken up by the iris cells which deliver iron to iron binding proteins, say apoprotein, and the other proteins in the erythropoietic tissue. It is better tolerated than iron dextran complex and has very low incidence of antigenicity. Half-life is 90 minutes and the dose is usually 200 milligram given IV slowly and intermittently up to 1 gram in a period of 14 days. Many do not prefer IV infusion. Therefore, amount of the fluid as normal saline should be as minimal as possible. Avoid simultaneous use of oral iron, and it can be given repeatedly in hemodialytic patients. It is reported to cause renal tubular damage because high renal iron uptake is there. Method of administration is that an infusion of 200 milligram in 100 ml of normal saline may be given IV in 15 minutes. If patient can tolerate, direct injection can also be done IV. Repeat administration of such infusion on every 5 different days within a period of 2 weeks to a total cumulative dose of 1 gram. In acute hemodialysis dependent chronic renal disease, a single 100 milligram doses can be given over a period of 2 to 5 minutes. Alternately, one may give infusion equally distributed over a period of 15 minutes. A test dose is needed, then dilution should be 1 milligram per ml. Only then 2 milligram per ml solution should be. Method of administration of ferric carboxymaltose, 2 doses at least 2 days apart, yes, at least 7 days apart. Currently it is available as 750 milligram in 15 ml, and dilution is done that 750 in less than 250 ml of the 0.9 normal saline, providing a concentration of around 2 milligram per ml. Now, rate of administration is slow, so that 100 milligram per minute is given. Usually 15 minutes, maximum 60 minutes is the. Adverse drug reactions to parenteral iron are common with iron dextran, particularly when it was formulated with high molecular weight dextrans. Currently it is formulated with low molecular weight dextran, and there is found to be less allergic. Pain, pigmentation is the site of injection intramuscularly, even when we use that technique. Fever, joint pains, palpitation, wheezing, and there is a concern of malignant changes at the site of injection into the muscle. Newer IV formulations have protective carbohydrate shell or coat around an iron molecule. They are found to be safer in this regard, that is, in the allergic or antigenic potential. Iron sorbitol may cause disorientation and taste disturbance. Urine may turn black when use of iron sorbitol is done and patient know it. If chest pain, wheezing, a fall in blood pressure or other systemic symptoms occur with initiation of the iron infusion, it should be stopped immediately, and one should take precaution to avoid extravasation if the IV iron comes out of the vein, causes local tissue inflammation and sloughing. Abscess may occur. Generalized symptoms appear even after several days of infusion of a large dose of iron, and that can include arthralgia, skin rash, lymphadenopathy, low-grade fever, particularly patients with inflammatory disorders, rheumatoid. Risk of hypersensitive reaction is enhanced in patients with known allergies, severe asthma, eczema, atopic allergy, and immune-related inflammatory conditions. Risk of hypophosphatemic osteomalacia is reported with use of ferric carboxy. Now, this finishes with the discussion. Possible viva questions could be: would you like to continue oral iron therapy along with iron preparation? Question 2. Which iron preparation will interfere with MRI imaging? Question 3 is: which oral iron salt contains maximum amount of elemental iron? PGs may also be involved, and for them question is: which is the master regulator of iron homeostasis, hepcidin or ferritin? And question 5, what is the rationale behind giving oral ferrous sulfate as a single dose daily in place of divided 2 to 3? Other questions could be, how do you assess effectiveness of oral iron therapy clinically? And question 7 is the MCQ. The item is, the earliest indicator of response to iron therapy is, there are 4 choices, and the best choice is to be for students, postgraduates, and colleagues. Is a good review available on oral and parenteral iron therapy, which can homework for SDL 20 for students is, analyze 3 pharmacological characteristics of midodrine. Question 2, analyze 3 characteristics of cilnidipine. Number 3, explain why oral loading dose of chloroquine is used for the treatment of acute attack of chloroquine sensitive IVX malaria. Question 4, which other drug requires oral loading dose? And question 5 of PG is, what is many dose